Right. That also changed how I practice as well. And so that is, I typically use TDXD for patients with brain mets. It is interesting how we've always talked about, of course, if you have brain mets, you have a disrupted blood-brain barrier. But our traditional chemotherapy just hasn't worked very well with that, right? So it's just you need a more effective agent where whatever it is, payload delivery, in concentrations or at doses that are also tolerable to be able to cross that threshold and take advantage of that.
So it's good to have this option. It's now FDA approved for patients with metastatic hormone receptor positive breast cancer, and you can use it after endocrine-based therapy. So if I look at my treatment paradigm, usually in the first line setting, I use endocrine therapy plus a CDK4/6 inhibitor. In the second line setting, get genotyping, and then based on genotyping, another endocrine-based therapy. Maybe sometimes use endocrine-based therapy third line as well, but sometimes after second line, then move to chemo. And when we think of chemo, that's when we think of ADCs, and that's why I tend to consider TDXD. But I'm curious about your practice as well.
Yeah, so for the most part, I try to use endocrine backbone with targeted therapies first, second, third line, and then move on to chemo. And I completely agree with you. At the time where I'm contemplating chemo, that is when an ADC, such as TDXD, now with the data that we have in that first line setting, I would use that.